So I'm going to be starting on stereotactic body proton therapy indications and advantages. These are my disclosures. Again, I focus on proton research, so I have a little bit of I think a little bit more highly maybe of proton therapy than other people. And then I would also point out that my talk is based on current practice and technology, and that things are changing rapidly. And so in 2 years, this talk will be potentially dated. And if that's the case, I can't defend anything past that. For the purposes of the talk, SBRT and SABRE stand for Stereotactic Body Radiotherapy. And SBPT is Stereotactic Body Proton Therapy using protons. So there's a couple of learning objectives I'm hoping the audience will get from my talk. The first is I'm hoping you'll be able to better identify patients that may benefit from stereotactic body proton therapy over standard photon-based SBRT. And then maybe more importantly, I'd like to discuss which cancers proton therapy might be able to offer accelerated treatment. So not quite the 5-fraction treatment of SBRT, but maybe a hypofractionated approach of about 15 fractions over using standard conventional fractionated radiation. So the first published report on SBRT with photons was in 1995 by the group in Sweden. This is a picture of me with one of those early investigators, Dr. Naslund, in which they reported on 31 patients treated with SBRT to tumors located in the liver, lung, and retroperitoneal space. Patients were treated with doses of 7.7 to 30 gray per fraction over 1 to 4 fractions. And the idea for SBRT is that you come in at multiple different beam angles. And this is sort of a representation of a cyberknife treatment plan where you have over 100 fields. And you deliver this very conformal dose distribution where you get a very high hot spot right in the center where the tumor is. And then quickly the dose falls off and you get this low dose bath that you can see in blue. Now SBRT is generally defined in the United States as 5 fractions or fewer, and it's delivering an ablative dose with radiation to the gross tumor volume. It's currently being used in stage 1 non-small cell lung cancer, but also it's being used in low and intermediate risk prostate cancer, which you'll hear more about later, as part of partial breast irradiation in early stage breast cancer and DCIS. It's being used in primary liver cancer. I believe that'll be discussed later. Unresectable pancreatic cancer and in oligometastatic cancers. And so the question that I was proposed was, is there a role for stereotactic body proton therapy? Now before we get into that, we need to talk about why this is even coming up as a question. And that's because proton therapy is growing across the world. 10 years ago, there was only maybe about 10 or 15 institutes across the world. But this is currently the number of centers that are in operation here in the world currently. You'll see a focus in the US, a focus in Europe, and then a focus in Asia. And in just 2 years, you can see that things are growing even more. We've got more centers in the US, Europe, and Asia, and then you start seeing them develop in the Middle East as well as centers in India. So SBPT is currently being used at some centers. We did a survey in the United States and found that among 14 centers that 10 of them were using SBPT for different treatments. They're primarily being used in lung cancer, but also to some degree in liver cancer, and a few institutions are using it for prostate, breast, pancreas, and bone. Now the big concern with proton therapy is the cost. And this is a graph that's from a publication in the Green Journal by Gruters et al., in which they demonstrate the costs cost versus the number of fractions per treatment. And what you can see here is that if you're treating with 15 or 30 fractions, the cost of proton therapy is much more than a similar number of IMRT fractions. But when we're looking at fewer fractions of protons, they're very comparable to the cost of what SBRT is. So cost is not going to be an issue with respect to protons when we're talking about stereotactic body proton fractionation. Now, I do want to touch upon a bit of the physics behind protons, and before I start that, let's talk a little bit about photons. So this is the depth dose curve for photons that we're all very familiar with. Photons are just packets of energy. They have no charge, no mass, and so they kind of go right through you. So this is depth on the x-axis. This is percent of relative dose on the y-axis. And so because we had indirectly ionizing photons, we get a little bit of skin sparing, then we get the full dose, which slowly gets attenuated as it goes through the body. Proton therapy is different. Protons are charged particles that both have mass and charge, and so they'll go a certain distance and then deliver all of their dose at that one depth. And that's what you see here, this sort of characteristic Bragg peak. You have a low entry dose and you have no exit dose. Now, most tumors are more than 1 millimeter in size, so this is not very effective treatment if we just use it like this. But what we do is we use the spread out Bragg peak, which allows us to treat the full extent of the tumor. We still have no exit dose, but you do have a higher entry dose when we do it that way. Now, for protons, you can see the color wash dose distribution for a patient on the left, and for SBRT with photons, you can see the dose distribution on the right. What you'll first notice is that the low dose bath is very different between the photons and protons. And that's illustrated here in the DVH, where you see the lung dose with protons in the triangles here versus the squares with photons. So you can see a big difference there. That being said, if you look at the center, the area in red, the high dose area, you can see that it's actually a little bit worse with protons than what you have with the SBRT with photons. And so this is an important concept to be aware of. And part of the reason is because of the fact that there is some uncertainty in how deep we're delivering the protons. And because of that uncertainty, we don't just deliver the treatment just to the depth of the tumor, but we add a little bit of a margin, both anterior and posterior to the tumor, to ensure that we get full coverage. This is something that we don't necessarily need to do with photons. Additionally, there's other things to consider when trying to compare SBPT to SBRT. And that's the fact that not all centers have volumetric imaging for proton therapy. And as a result, our PTV margin may be bigger with protons than it is with regular SBRT with photons. Additionally, there are some advanced systems of photon delivery that can track the tumor and so can reduce the ITV volume, as well as the ability of doing respiratory gating, which we don't quite have at all the proton centers yet, so those can affect the ITV margin. So when considering protons as part of SBPT versus SBRT with photons, we need to think that protons could reduce the moderate and low dose volume of radiation and the associated side effects of that. But on the other side, we might increase the high dose volume, which might increase the associated side effects associated with the high dose volume. So it's a balance that we need to think about. So we're going to first focus on stage 1 non-small cell lung cancer, where I think we see the biggest benefit for protons in SBRT. In this review article by Gruters et al., they found that for patients with unresectable stage 1 non-small cell lung cancer, that 5-year survival rates were about 20%, so pretty poor with conventional fractionated radiation. In the mid-90s, the group at Loma Linda in California started using accelerated treatment course with protons to treat stage 1 lung cancer. They used 10 fractions to a dose of 51 gray. And this treatment regimen was adopted very quickly by the Proton Centers in Asia and Japan. And actually, when you review the literature on it, the 5-year survival rate is actually much better than what we saw with conventional radiation. It went from 20% to 40%. And this is just a list of some of the publications on the topic. You can see that the fractionation regimens vary from 10 to 20, but as low as 3 to 5, similar to what we're seeing with SBRT. But although the outcomes were so good with protons, they're also quite good with SBRT using photons. You can see similar 5-year survival rates from this review article. Again, we think with protons we might be able to reduce the toxicity, and when you look at all the studies published, you can see actually the toxicities are quite low. Pneumonitis, dyspnea, esophagitis, they're low across the board, so we don't see a big benefit when we look at it like this. You do see maybe a little bit more pneumonitis with the SBRT versus protons, but it's not that much more significant. And so actually what centers started to do was do some dosimetry studies to see where we might see an advantage for protons versus photon-based SBRT. And there's a number of publications on this. This is some of the raw data from the studies in which they compared with the same patients doing a photon-based SBRT plan versus a proton. This is a lot of numbers to look at, so I'll just draw your attention to the numbers below, where you can see sort of the average mean lung dose difference of about 1.7 gray for SBRT. The lung V5 difference was 10% and the lung V20 was 1%. Now the clinical implications of this are a little unclear from one patient to the next. I think the thing that people should think about though is that these are the average differences for all patients, and that there are patients who have much smaller difference where there's really no point in using the protons, but other patients where there is a big benefit. And so we need to figure out who those patients are. And so when we look at the conclusions of these different studies, they really kind of can help guide us. So the first two studies used very small peripheral tumors, and they really didn't see much of a benefit for protons. The UF study that we published actually did show a benefit, and I was trying to figure out why, and I realized it's because the tumors we were treating were much larger. So larger tumors, we'll see a bigger benefit for protons. Excuse me. At MD Anderson, they found that tumors located more centrally, as well as superiorly next to the brachial plexus, provide more of a benefit with proton therapy. And then in Japan, they found that bigger tumors and multiple tumors benefited more. So here's an example. Here's a patient with a small peripheral tumor. You can see the color wash dose distribution for photons on the left and protons on the right. You can see that dose distribution is really not that much different. There's a little bit more low dose with the SBRT plan versus the proton-based one, but it's nothing clinically meaningful. So I wouldn't necessarily need protons for this case. But for a larger tumor, and this is an exaggerated case, this is not stage 1 lung cancer, but it's just to get the effect that with the color wash dose distribution for an IMRT plan on the left versus protons on the right, you can see that you're going to have a much better sparing of the heart, lungs, and esophagus. And then for centrally located tumors, you can see that you're going to have a benefit for these patients. You can see the protons on the left, SBRT on the right. The low-dose bath in blue, it's much more significant in the SBRT plan versus the proton-based SBRT. Here we're able to use the mediastinum and spine as a backstop for protons, as opposed to SBRT where you're having to push the dose away from the esophagus, which ends up pushing it into the ipsilateral area of the lung. And this is important because of the publication from Bob Timmerman several years ago, which found that patients being treated for centrally located tumors with SBRT actually had a higher rate of grade 3 toxicity. And here's the graph of Kaplan-Meier curve for late toxicity, and you can see at 24 months, about 50% of the centrally located tumors had developed a grade 3 toxicity. So working on that at UF, we've actually been treating these centrally located tumors with stereotactic proton therapy. And here's a list. We've treated about 20 patients. These are where the tumors are with relationship to the primary bronchial tree and the 2-centimeter margin. And we've had pretty good outcomes. And so what you'll see is that when you have got a small tumor in the dome that's 1 centimeter, you don't see much of a benefit for using protons. But if you have a larger tumor, like say a 6-centimeter tumor, you can see a much larger sparing of the liver that you wouldn't be seeing with SBRT. We don't see that in all the locations. You can see the caudal area, a 6 centimeter tumor, you had similar sparing whether you use SBRT or protons. So here again, location and size matters. There's been a meta-analysis of different radiation treatments for liver cancers, and this was published in the Green Journal in 2015. They looked at conventional radiation, SBRT, and proton therapy. And some of the proton studies were the SBPT type fractionation. And I'll point out that the 1-year survival rates were quite good with SBRT and protons compared to conventional radiation. The progression-free survival was marginally better with the protons. And the grade 3 radiation-induced liver disease and late toxicity were more favorable for the proton cohort. Now, there's instances where we can't deliver SBRT and we're stuck with conventional fractionated radiation doses. And when that happens, I'd urge people to also, again, think about protons and the ability to use protons, maybe not in a stereotactic manner with 5 fractions, but in a hypofractionated accelerated manner. And this is a study that was published from MD Anderson, MGH in Harvard, and University of Pennsylvania, where they explored treating primary liver cancers with 15 fractions of protons to a dose of 58 to 67 gray. They decided on the ultimate dose based on the mean liver. They needed to make sure it was less than 24 gray. And you can see that when they were able to treat the tumors to more than 60 gray, the local control rate was outstanding, versus if they had to compromise the dose, the recurrence was much higher. So I think with proton therapy, if you're able to get to that higher dose, we're going to see better long-term outcomes. What about SBRT and prostate cancer? So you'll be hearing a talk about this shortly. SBRT is being used in both low and intermediate risk prostate cancer with 5-year biochemical free survival rates which are quite comparable to conventional fractionated radiation. The problems with SBRT for prostate, though, is that there have been some concerns about the late urinary toxicity. There's also been concern about testosterone decline because of radiation to the testes. And ultimately, we don't have the 10-year follow-up on these patients yet. And so there's still some uncertainty in the minds of some of the physicians and patients about late toxicities or recurrences that may occur. So there has been some dosimetric studies that have looked at using proton therapy as part of stereotactic body treatment versus CyberKnife SBRT. This is a study that the Georgetown group did in collaboration with UF, and you can kind of see, sorry it's not the greatest image, but the CyberKnife plan here on the left, the proton plan on the right. And ultimately what they saw in the study was that protons-based stereotactic body radiation could decrease the dose to the penile bulb, to the urethra, rectum, and body. But on the downside, as we talked about before, because you can have that higher dose with protons, because it's not quite as conformal in the very high dose area, the bladder receiving 32 gray, and this is a prescription dose of 35 gray, was much higher with protons than with the photon-based SBRT. And that's important because we did say that late urinary toxicity is of some concern. And so if that late toxicity is because of the urethra, then we may see a benefit with protons. But if it's because of the high dose to the bladder, then we may not see a benefit with protons. Now, there has been some early reports of stereotactic body proton therapy for prostate cancer. Carlos Vargas at the Mayo Clinic recently reported on 49 men treated at 38 gray and 5 fractions. And with early outcomes, very early, they showed that there's no grade 3 toxicities and that quality of life was maintained. Again, this is very preliminary data. We still need more mature data. But the Proton Collaborative Group, which is made up of a number of community and academic hospitals in the US doing proton research, does have a randomized trial that's currently enrolling that's randomizing patients to 78 gray and 39 fractions versus an SBRT fractionation of 38 gray and 5 fractions. Again, on this notion of accelerated treatment, Moderate hypofractionation with proton therapy may also be effective if we find ultimately that SBRT may not be quite as good. This is something that was pioneered by Dr. Kapilian, who will be talking later today. And at UF we did a study that was recently reported with a median follow-up of about 6 years, in which 228 patients were treated at 70 to 72.5 gray at 2.5 gray per fraction, and we showed excellent biochemical-free survival of 98% for low risk, 93% for intermediate risk, with low rates of grade 3 toxicity, less than 1% for GI and 2% for GU. Lastly, just to mention SBRT for pancreatic cancer. It's being utilized in patients with unresectable disease. It's a well-tolerated treatment with good local control. The problem is that ultimately you need to compromise on PTV coverage a lot of times to meet the strict small bowel and stomach dose constraints. And overall patient survival is poor. With proton-based stereotactic body radiation, there have been a couple of dosimetric studies that have been published, and they generally show that the low-dose radiation to the bowel is less with protons. But on the other side of things, the high dose might be a little bit higher with protons. And that ultimately might be the more important factor when we're talking about bowel toxicity for pancreatic cancer. So I'm still a little unsure what the role of protons will be for stereotactic body treatment of pancreatic cancer. But again, going through this accelerated treatment when you've got a much larger target volume, so this is a study from MGH using protons as a preoperative dose to a very large volume. As illustrated here, this is our proton plans on the top versus photon SBR accelerated treatment below. So for these large target volumes, doing an accelerated preoperative dose, they definitely saw a big benefit for the patients, dosimetrically to the bowel, to the kidneys, to the liver. Unfortunately, again, with pancreatic cancer, outcomes are not so good, because despite a 80% local control rate, there was a 20% long-term survival. And University of Maryland is also looking at accelerated treatment regimens, not quite 5 fractions, but 10 to 15 fractions to deliver proton therapy for advanced pancreatic cancer. So in summary, stereotactic body proton therapy is indicated in cases where stereotactic body radiation delivery is more challenging. So in stage 1 lung cancer, I think for patients with centrally located tumors, as well as larger tumors, it can be a very good treatment. For patients with liver cancers, again, tumors located in the dome of the liver, as well as larger tumors, are going to benefit more. Aside from using protons for a 5-fraction treatment approach, I think you can use it in an accelerated manner in other disease sites where we're not using SBRT, so things like locally advanced lung cancer, like I talked about, and pancreatic cancer may be of even more usefulness than in the SBRT setting. And with that, I'd like to thank everyone